Yes, the floor is yours, Professor.
Thank you very much, Landa. So this is Dr. Emile Ngabo. I'm a physician, or simply speaking, I'm a medical doctor with specialization in infectious diseases and epidemiology and disease control as well. So I currently serve as the operations director at Oazis Health. I also serve as an investigator in clinical trials, trying some new medications that might be ready to fight bugs which are resistant already to the existing drugs. So I'm just holding those positions as of now. So if we say that I'm the operations director at Oazis Health, Oazis Health is a grassroots local organization based in Rwanda, in Kigali. And if I say Rwanda, that is in Africa. And we usually locate it at the heart of Africa. So we are used to say that Rwanda is located at the heart of Africa. So it is in the sub-Saharan region. It is in East Africa. So Oasis Health is located there in Rwanda. It just prioritizes health education or simply capacity building in the area of health for the healthcare professionals, the One Health practitioners as a whole. And we also target the local communities in terms of raising awareness. So beyond that, we also do pioneer researches across the health sector. So I think I've brought to you in a nutshell a bit overview of what is Oasis Health. So going straight, I'm going to be talking about antimicrobial resistance and One Health. Simply, the way bugs get to create resistance against the medications that used to treat them. So, and once we say this topic, or once we discuss this topic, we shall be extending our vision not only to the human field, as long as I am a medical doctor, but also focusing on the other two fields, which are not human health. We'll be extending our eyes to the environment and also extending our eyes to the animals' health. And we shall see the way the three aspects collaborate or interact to destabilize the human health as a whole. Okay, the overview, it will be discussing the intro on AMR, the burden of AMR, and the way AMR is related to One Health. We shall see the efforts, the global efforts in place as we speak. What is the World Health Organization doing? What does the NEP doing? What does the FAO doing just to address this issue? And we shall also see what is my role as me, as Emil, as Lando, or anyone else in this talk. What can he do? So we just want anyone at the end of this talk be able to relate AMR and One Health, and also be able to understand the efforts in place as we speak, and his or her effort, what can he or she do just to address the burden. Here we see a doctor. He might be a human doctor. He might also be an animal doctor, a vet doctor. He might also be, why not? He might also be an agricultural personnel, just dealing with someone else in front. Scary. You see, this boy in green with a green face and also a green attire, he might be a bug. If I say a bug, understand the bacterium, a virus, a parasite, why not a fungi? So simply it's a bug, it's a microbe. And this doctor is facing the bug and they're praying chess. Uh, so who will be winning the game, the battle? So in Leo Rife, the doctor was supposed to be beating this bug, but up to my understanding and my perspective as I'm seeing this game, it is possible that the bug will be beating the doctor. So initially, long time ago, uh, humans did not know um, how to treat infections. And whenever anyone got a disease or simply a very simple or minor cut, I mean a minor wound, he would die of that cut. Like going back to the World War One or simply World War Two, many of the soldiers died not due to the bullets, not due to the guns, not due to the knives, but due to the simple infections in the cats that attack the simple infections that was resistant that infected their cats, their wounds, and they could die of those minor wounds. So later on, it was discovered by framing some new medications, that is penicillin, that would be applied to um, that would be applied just to cure those bugs. So, and that was a very, very big achievement where the human sector was able to fight or to combat those bugs, simply the bacterias, because penicillin was an antibiotic that is targeting bacterias. So, however, Fleming also said, if it happens that you expose this newly developed drug, which is penicillin, and you expose it to a bug in a very small amount, there is a likelihood that the bug will develop the knowledge and skills and the strategies to combat that innovation, or simply that penicillin, that medication. And that what he was describing, um, he was describing the phenomena of resistance, the way bats get stronger to beat the existing drugs. As I've been saying in a definition, MR, or simply antimicrobial resistance, occurs when bacteria, viruses, fungi, and parasites no longer respond to the antimicrobial medicines. If we say antimicrobial resistance, some majority of the people understand antibiotics, but resistance does not only occur on bacteria, it also occurs on viruses, fungi, and even parasites. Simply speaking, for malaria parasites, they create resistance. So for the fungi is also to create resistance. Virus is the same, and even bacteria is the same. Like in Rwanda, we've seen some trends of resistance in malaria. So the medications that we used to use, which is a combination of artemether and remifentrine, known as Coartem, there is a resistance of the malaria parasites against that combination, which was actually a very known and very good drug, but it is no longer a good one because the germs have learned how to fight the medicine. Okay, here we just want to see what are the factors, the leading factors in antimicrobial resistance. So I'll be using a pointer, raise a pointer for, yeah, sure. So there is poor sanitation. If we say poor sanitation, it is the people are not washing hands. and if they don't wash hands, they take their bags to the other people. They shake hands with the other people. They're sharing bags. They're sharing those microbes. If I do have resistant microbes, I'm gifting you microbes as well. Poor quality of antibiotics. So in case the regulatory framework is not a good one, there is a possibility that the pharmaceutical industries might produce poor standardized antibiotics. So, and in case they're not good quality, the bacteria will be learning very easily how to fight the bugs, because the antibiotics that was brought closer to the bugs was not stronger enough to make an effect of killing the bug. So if the bug does not die, it will be creating a resistance. It will be learning the new approaches and strategies to fight the antibiotic. So we see here excessive use of antibiotic in agriculture. So for the people in agriculture here, so they sometimes, or even in veterinary practice, like here in Rwanda, we do have some substandard or poor quality standard use of antibiotics in poultry, in cows, so in farming of pigs. They know that if you provide more antibiotics to their animals, they'll be growing faster and bigger easily. However, the antibiotics actually does not does not lead to the overgrowth of the cows of the farm, but it only targets bacteria. So if you just want your cow to grow, you just have to feed it, not to give antibiotics. I think this is understandable. Increasing risk patient population. So the population of ours is aging, and as they ages, their immunity goes down. And as their immunity goes down, they are prone to getting more disease frequently. And as long as they get more disease frequently and they cannot fight them easily, so there is a risk of more infections, and some of them they are resistant, and resistance will be very simple here. Inadequate infection prevention control strategies. So we are here for the inadequate IPC. In our clinics, in our farming, we are not protecting ourselves. And as we can get some diseases from the cows, the pigs, the poultry, and even the diseases can also spread across from one cow to another, one hen to another, one pig to another, one rabbit to another. So the infection can easily cross. There is also a shortage of rapid diagnostic facilities. In case there is availability of rapid diagnostic facilities everywhere, we are very sure that it will be easy for us to test the infection. And if we can simply test the infection, we can treat knowing what we are treating. So there is here also in the lead inappropriate antibiotic prescribing. Majority of the people who are suffering from flu or common cold, they just take antibiotics. The most common practice here, it is to use amoxicillin, which is not simply substandardized practice, but a very, very long practice, because the majority of the upper respiratory infections, the majority of them, they're viral, not bacterial. Yes, there is also over prescribing of broad spectrums. There is no need of providing a wide coverage antibiotic while you can be sure that there is a narrow spectrum antibiotic that can target that simple bug that the patient or the animal has. So it is better to go straight with a narrow spectrum instead of a wider spectrum or a broad spectrum antibiotic, because that broader spectrum antibiotic will be of a great importance or use whenever you have multiple germs, or whenever you have many germs that you want to target, instead of that one very simple one that can be treated with a narrow spectrum antibiotic. There is also antibiotic misuse and even global travel. I can be here in Africa, and Landa, or a friend of Landa, invites me to go to Jordan, and I fly from Rwanda to Jordan with my resistant TB. And once I reach Jordan, in case my friends there in Jordan does not protect themselves, I'll be giving them my TB, and that TB might be resistant, or not simply TB. It can also be malaria, a resistant malaria. And in case the medication that are being used in Jordan, the bugs have created resistance against those drugs, so I'll be spreading resistant germs in Jordan as well. Okay, what might be the mechanisms of resistance? How do the resistance develop? So just one minor or main, not minor, mistake that is commonly made by people trying to talk about resistance. It is not human who get resistant. It is not medication which get resistant. It is the bug which creates resistance against the medications. And here are multiple pathways through which the bugs can create resistance. So the first one is alternative metabolic pathway. Just in case the bacteria used to use a pathway A to create protein B, and the medication used to come here to interfere this pathway of creating proteins that are essential to the survival of the bacterium. It happens that the bug can know, this medication used to come and attack this procedure. So why not change the other way and we create the proteins that are essential to us, but using another methodology, another approach? And that is resistance, because once that drug come again to block the pathway, so it will find the bugs has learned a new methodology to survive without depending on the past pathway. So there is also here cell membrane impermeability. So it can happen that the medication used to come here and destroy the bug from the surface. So the bacteria can now create an impermeable membrane, and a resistant membrane, so that the medication cannot act here or cannot get inside. So there is also evolution of target structures. So in case the bacteria used to come and target a certain structure, the bacteria learns a way to counteract that effect. There is also other bacteria or other viruses that push outside the medication. The medication comes and enters, but the bug learns how to push it out, to send it out. And there is also production of inactivating enzymes. The bacteria or the bug, the virus, the parasite, they just create enzymes that will go destroy or lyse that medication. So what is the burden? In 2019, 1.2 million lives was claimed globally. So simply 1.2 million people died back in 2019 due to the resistant antimicrobials, to the resistant bugs or the resistant infections. And it's projected that in 2030, 2030, 24 million people will be pushed into extreme poverty due to the out-of-pocket expenditures that are associated to the antimicrobial resistance. Once you have a resistant bug and you are supposed to be hospitalized for 2 days, it can take 10 days or 20 days, and you even go abroad to seek medical care due to the resistant bugs that have attacked you. So you understand the way antimicrobial resistance can push you into extreme poverty. So in 2030, 24 million people are expected to be pushed into extreme poverty. And in 2050, 10 million yearly deaths shall happen. It was 1.2 million deaths in 2019, and in 2050 it shall have been multiplied more than 10 times. So it will be 10 million annual deaths. And there will also be a fall in GDP by 2% or 3.5%, from 2 to 3.5. Drug-resistant infections are now a leading cause of deaths worldwide. Back in 2019, you can see the way antimicrobial resistant infections was killing more people than HIV, and even than breast cancer, and even than malaria. What is worrisome here, it is that majority of the funds, they are targeting malaria, they're targeting breast cancer, and they're targeting HIV. There is many projects that are targeting those diseases. However, limited projects are targeting antimicrobial resistance, whereas antimicrobial resistant infections or drug resistant infections kills many more people than those next diseases. And here, if you see sub-Saharan Africa, where I live, that is in Rwanda and other countries, so they share the greatest burden than South Asia, than Southeast and East Asia and Oceania, North Africa, Latin America, high-income regions, and Central and Eastern Europe and Central Asia. So the greatest burden is in Sub-Saharan Africa. There was a mapping in Africa of the antimicrobial resistance and antimicrobial use partnership, and it was found that only 5 of 15 bugs, which are the WHO's priority, can be consistently tested in bacteriological testing labs in Africa, in most countries, only 5 of 15. And it was seen that only 1.3% of the biology laboratories across the 14 countries in which the study happened, they perform bacteriological testing. You understand how serious this is. The impact of antimicrobial resistance. People die more than usual. There is also increase of the morbidity. People get disabled due to the antimicrobial resistance. Majority of the treatment fails. Surgery, they fail due to the post-surgical infections. Medical procedures like chemotherapies, they do fail due to, the chemotherapies, the treatment of cancer. They do reduce the immunity, and once they reduce the immunity, you can get more infection, and in case the infections are resistant, they cannot be targeted by the medicines that used to target them. The next will be the death, increased healthcare costs due to longer hospitalizations, expensive treatments, and so on. Then, how does this relate to the environment, the animals, and even people? You know, infections can cross from human to the cattle, and from the cattle or simply from animals to the humans. And the infections can also spread from human to the environment and from the environment to the human and so on. So here, the recent cases of Ebola, Ebola virus disease. We also have had Marburg virus disease here in Rwanda. And the case fatality rate is very high due to Marburg or Ebola virus. So the majority of the people who faces the disease, they do die. And those infections, they are coming from bats. The bats, if you from flying bats. Once you get those infections from the bats to the human, there is a more than 80% case fatality rate. So there is a likelihood of dying. And once you get, and that disease can also spread from humans to the animals as well. You can also get the infections from the environment to human. So here, Rift Valley fever. So you can get, there is many cases of Rift Valley fever that we had here in Rwanda. There is avian influenza, that it hit majority of the Western countries, Ebola virus disease in DRC and even in some Western countries. And here it is in Rwanda specifically, the Marburg virus disease. The people who were suffering from Marburg virus diseases, but we conquered it successfully, and we low put the fatality rate down to below 30 from 90s. So you also know mpox, monkeypox. Recently had a double burden of mpox and even Marburg virus disease. And you also know rabies. And the case fatality rate of rabies is 100, whereas it is a very simple preventable disease. Once the dogs are vaccinated, there is a less likelihood of getting rabies to the humans. You also know anthrax. Anthrax is a very rare disease that comes from animals, but its case fatality rate is high. What is the global MLR response that we can map from 2010? In 2010, the FAO, the WOAH, founded, they created the tripartite, and the tripartite was of the three organizations, and that tripartite aimed to jointly lead the tackling of antimicrobial resistance, and currently it has been made a quadripartite due to the engagement of UNEP, the UN Environment Protection Office. So in 2015, they developed a global antimicrobial resistance plan, a global action plan on antimicrobial resistance. And in 2016, there was a UN political declaration on AMR. In 2019, there was an initiation of the AMR Multi-Partner Trust Fund to tackle antimicrobial resistance in the One Health approach and supporting the countries to develop the national action plans on AMR. In 2020, they engaged the Environment Office of the UN into the tripartite to make a quadripartite to ensure that the environment is represented. So, how can we use the One Health approach to combat antimicrobial resistance? There is a global MR crisis with high deaths, treatment failures. However, if we can enforce surveillance, we track down the resistance pattern um, globally. We know these germs are resistant in Rwanda, and they have resisted this medication, this, and this with this done. And we are sure that we have a full list of the germs and their resistance. We can know how to treat the infection, not only in human, but also in animals as well. Stewardship. We have to promote responsible antibiotic use. You only use antibiotics when they are needed, and when they are not needed, you do not have to provide the antibiotic. Innovation. Development of new antimicrobials. In case one antimicrobial have been resisted, we can develop new antimicrobials. Education and raising awareness and behavior change. In case we empower the communities about the resistance, they can develop new behaviors that can target antimicrobial resistance. If we go through this journey and we combine everything we see on this map, we shall have reduced the MRI impact. We are sure that the deaths will lower and treatments will be more effective. The methodologies to fight AMR, they're sometimes categorized in three: reduce the unnecessary antimicrobial use, limit the transmission of infections, and develop new treatments. You just look into how you can get an alternative treatment. Here are the weapons against AMR. Vaccines. If you get vaccine, you are protected from the disease. And vaccination, it is not only in humans, but also in animals. Alternative antimicrobial therapy. In case you have flu or common cold, it is not advisable to take antivirals or antibiotics or antifungis, because the immunity itself can even fight the common cold. You just take the remedies, because some of the remedies are known to boost the immunity and they can fight the common cold. Antimicrobial stewardship programs in hospital settings and also in animal farming settings. Education and awareness. Research, surveillance, on One Health approach, not only surveillance or tracking the bugs only in humans, but also in animals. We have NAPs, National Action Plans, across all countries. In case they are fully implemented, ensure that we'll be fighting the AMR well. Government rules and regulations as well. Okay, what have we developed at Oasis Health? At Oasis Health, we have developed an antimicrobial resistance, antimicrobial stewardship program, where we empower One Health practitioners about antimicrobial resistance. We empower them. What is AMR? How does AMR impact the three aspects of One Health? And what are the strategies that we can use with a One Health approach to combat antimicrobial resistance? It is a certified course that you can take anywhere, which is self-paced. In case you are interested, I'll be sharing your link in your inbox. Okay, thank you. In Rwanda, we say mulakoze. In Swahili, we say asante sana. And in Arab, my friends will be helping me. So in case there is a question, I'll be happy to receive it. Thank you very much. And it was a pleasure to present to you. Thank you.
Murakoze, Professor Imi, for your awesome and informative presentation. Thank you so much for sharing with us your knowledge regarding antimicrobial resistance in One Health approach. Again, thank you so much. Yes, we have a lot of technical questions from our attendee. Maram, please go ahead, dear. Unmute yourself and ask your question. مرام يا مرام, can you hear us? فيك تسمعينا؟ Oh, okay. Tell me. Let me stop recording, and so